All right, I want to thank everybody for coming to our December Grand Rounds, our quick science presentations featuring three of our faculty members from the Department of Psychiatry. I'm Michael Paul Shelmo. I'm one of the co-chairs for the Grand Rounds Committee. For everyone who missed it, CME code today again, 5654. And we will get started here very shortly. We'll be starting with Dr. Michael Bronstein. He is an assistant professor with a joint appointment in psychiatry and the Institute for Health Informatics. And prior to his postdoctoral work, which was here at the University of Minnesota, he received his PhD in psychology from Yale University and his bachelor's in psychology from Washington and Lee University. His research seeks to understand cognitive pathways that lead to and maintain discrepancies between beliefs and reality. And his research programs use methods from data science to examine how these pathways operate in the context of specific symptoms, such as delusions and suicidal ideation that transcend diagnostic categories. Specific areas of research interest include vaccination beliefs, conspiracy theories, and so-called fake news. The title of his talk today will be Biased and Inflexible Interpretations, Associations with Personality, Emotions, and Psychopathology. And please, if there are any questions, use the from Zoom, please use the Q&A function or the chat, and I will help. We'll have a little bit of the 20-minute talks from each of our panelists, and then a bit of time for questions at the end. So thank you, and help me welcome Dr. Bronstein.
Introduction, I appreciate it. So I'm going to tell you today about work that we've been doing since the last 6 years since I was in graduate school. And this is work on biased and inflexible interpretations, as Michael Paul mentioned. And before we get into exactly what biased and inflexible interpretations are, I just want to start by talking a little bit about interpretations in general. So a lot of the things that we encounter in the world are ambiguous, right? And so this image here is a great example of that. You might interpret it as a duck, you might interpret it as a rabbit, depending on your point of view, right? But you have to make an interpretation. You have to decide what this is going to be. And this happens in the context of these visual illusions, but it also happens in our day-to-day life, right? So, you know, maybe when you were walking here, you said hi to a colleague and maybe they didn't say hi back, right? And that might be because they're upset with you. It might be because they were on a call and trying to get in some last minute conferencing, right? You have to make an interpretation, and the way that you interpret that might affect your relationship with that person. It might affect the emotions that you feel, whether you feel sad or whether you kind of discount this as just this person was busy, right? And so these interpretations really have a consequence for our mental health and our relationships with other people. And one could be biased in your interpretation. So it might be that you systematically tend to interpret things in a particular way. Like I tend to see this image on the screen as a duck. Other people might tend to see it as a rabbit, right? And that might play out in the context of social relationships as a more negative or a positive interpretation bias. And research suggests that the way that we interpret things really does, like I said, have important consequences for mental health. So this is a theoretical model of depression, right? And the things that lead to symptoms of depression. And you can see that biased processing, things like interpretation bias, play a really central role in these models theoretically. And that's been backed up actually by research, that this actually really has an important effect on individual symptoms and might be bolstered by biases in attention and memory. So that's bias. And a lot of the research has been done on interpretation bias. Okay, so what we see in the literature a lot is people who study interpretation bias alone. They say, look, people with depression or anxiety have a negative interpretation bias, and then they kind of stop there, right? But importantly, interpretations can be biased in ways that are helpful and not, right? And the actual functional effect of bias probably differs according to how flexibly one holds an interpretation. So for example, like let's say that I did say hi to Kelvin in the hall and he didn't quite hear me, right? Because he was on a call. If I then don't account for the fact that after he comes up and tells me, hey, I was on this conference call, you know, it seemed like you were trying to tell me something, but I didn't really hear that. If I still persist and say, oh, Kelvin's mad at me, right, that's going to have a really different effect on my relationships and my mental health than if I'm more flexible and I say, oh, yeah, of course, I'm going to change my belief to account for this new evidence, right? So flexibility with which we hold interpretations might modulate the effects of interpretation bias, and it might actually be the thing that's more important for mental health, right? A flexible interpretation optimally will incorporate past and current attributes of unfolding situations, right? So considering current and past evidence, integrating them into one interpretive percept, and also hopefully if we're flexible, it might let us effectively select responses as our environments evolve. All right, and theoretically, there's been some work suggesting that inflexible interpretation, it might actually be really helpful. And if you are inflexible, you might have higher symptoms of depression, right? There's theory that suggests that. At the time we started this work, there really wasn't a lot of empirical data that teased apart bias and flexibility and said, what are the actual differential effects of those on symptoms? And so we really wanted to delve into this more back when I was in graduate school. And so we started to take a look empirically. So our first study said, all right, well, what if we just pit inflexibility and bias against each other in looking at symptoms of depression and anxiety and see what it is that actually starts to be related. And this is our first paper. It's published in the Association for Psychological Science, Journal Psych Science. And these are the authors in the title. But anyway, so we did an online study and we recruited 212 individuals. We oversampled them for depression and anxiety, right? So these individuals generally have much higher levels of depression and anxiety symptoms than the general population. And we had them do a novel task called the emotional Bayes task. And the emotional Bayes task is based on the original bias against disconfirmatory evidence Bayes task, which was designed to look at inflexibility in schizophrenia. And that task looks as follows. So people view a series of scenarios. Every scenario consists of 3 statements, and they see these statements in series. So they'll see statement 1, then they will rate the plausibility of these different explanations for the events in the scenario thus far. They'll see statement 2, they'll do that again, and they see statement 3, they do that again. The explanations stay the same across those 3 ratings within a scenario. And across scenarios, the explanations can be grouped into different kinds. So there are lure explanations, which are initially most plausible and then become progressively less so as scenarios continue. Absurd explanations, which stay progressively implausible throughout the whole thing. And then true explanations, which start as moderately plausible, but then become most plausible by the end of the scenario. And you can see an example of one of the scenarios here. Importantly, there's not really a relationship here between the emotional valence of the lure statements and the true explanation. And so the direction of belief revision from an emotional perspective doesn't have any systematic quality in this original Bayes task. All right, so we decided that we wanted to make that a little bit different. And so we did a couple different things. So first, we introduced a systematic relationship between the lure explanations emotional valence and the true explanations emotional valence. So we constructed some scenarios that were negative to positive, or you started with a negative emotional interpretation that was something that seemed really plausible. And then by the end, a more positive one was most plausible. And we also had the opposite, positive to negative. And we also redesigned all the scenarios to focus specifically on interpersonal concerns and concerns that were really important to individuals with depression and anxiety. So things like you are being socially rejected by others, social humiliation, things like that. All right, and this is an example of one of our scenarios. So in this particular case, it starts out that it's your birthday and you receive a few messages on Facebook, and it seems like maybe people didn't care, they didn't remember your birthday. But by the end, it becomes more plausible that people were just waiting to surprise you, and actually they do care about you, right? And hopefully people make that emotional switch over the course of the scenario and they revise their beliefs. All right, from those scenarios, you can pull out 2 interpretation bias components, a negative interpretation bias and a positive interpretation bias for each scenario type. And also you can pull out inflexibility. So the disconfirming the negative scenarios here, it's going from a negative emotional valence to a positive one, right? So this is interpretation in a hopeful positive direction. And in a multiple regression model, if we put all these things into the model predicting depression or predicting anxiety, what we see is that negative interpretation bias matters, right? Higher negative interpretation bias is associated with higher symptoms. And also above and beyond that, inflexibility is associated. And actually, inflexibility is the more reliable effect here. So that was our first indication that maybe we were onto something. It's not true for disconfirming the positive scenarios, though. So if you're going from positive to negative in fact, it's bias that matters, and that gives you an association with symptoms. So this was our kind of first indication that, inflexibility does actually maybe matter above and beyond bias, at least in the disconfirming the negative scenario case, and that looking at things in a valence-specific way might really be important because the relationship between inflexibility and symptoms might be differential across valence. Okay, so then we're like, all right, well, why? Why is it true that inflexibility might be associated with depression and anxiety? And one of the things that we thought about is that it could be that inflexibility actually impacts emotion regulation, and that might be the thing that leads it to be related to symptoms. Right, and so this is our second paper that's been published and where we looked at this. And in this paper, we recruited 2 samples. They were a little bit larger. And again, we oversampled individuals for depression and anxiety. All right, and this time we tried to focus specifically on the disconfirming the negative scenarios because those were the ones where we were seeing that relationship with inflexibility. And so I'm showing you the results of both studies at once here, so you can see how reliable things are. And you can see that, again, we replicate this effect where inflexibility is related to depression and social anxiety symptoms above and beyond the interpretation biases. And that actually across studies, the inflexibility association is actually more reliable than the bias one. So that, again, gives us some indication that inflexibility might be important. And then we started to build structural equation models to look at different emotion regulation constructs to see whether they might be mediators of the relationship between inflexibility and symptoms. And these are the models for both studies again. And what you can see is that dampening of positive emotion is a statistically significant mediator of that relationship. And it's such that if you're more inflexible, you tend to do more dampening, and that actually leads to symptoms of depression and anxiety. We've seen this now across a bunch of other studies, that dampening is really related to that inflexibility. We see this in samples recruited for eating disorders, for example, in data that I'm not going to show you today. But this is something that's really reliable. So it does seem that that inflexible interpretation does do something to emotion regulation in a way that causes people to dampen. We think that part of it might be that it encourages co-dampening of positive emotion. So you could dampen by yourself in your head and say, good things won't last for me. I shouldn't be happy about this. It's only going to be temporary. It was just luck. It'll be bad for the future. Or you could do it with somebody else and talk about those kind of things with somebody else. And we think that that's that co-dampening that's actually really important. But I'll show you more data on that in a minute. Okay, so all these studies so far that I've shown you suggest that inflexible interpretations, if they're negative, are reliably associated with depression via that dampening of positive emotion. And negatively biased interpretations are also related to dampening, but each effect persists, controlling for the other. And so we think that dampening might be this mechanism via which initial negative interpretations both persist, right, which is some of the work by Kubi and some others who are looking at this now, but also might be a way that it causes depression. And we think also that engagement in emotion regulation strategies for negative emotions specifically, like RNT, repetitive negative thinking, and positive reappraisal, those might be driven more by interpretation bias and not inflexibility. So we looked at those 2 things in models that I didn't show you, and there was no effect for inflexibility. So it seems to be specific to dampening of positive emotion. Okay, so then we thought, all right, well, this affects emotion regulation. It also might really affect people's false beliefs. So one of the things that individuals who have suicide ideation often do is they often think that they're a burden to other people. And research shows that, in fact, when you look at those people and interview the people that they think that they're a burden on, oftentimes that's not true. They are not, in fact, a burden to others in the way that they think they are, right? So they are overly negative in their interpretations. And so we start to think, well, is it possible that inflexible negative interpretations might lead somebody to think that in these social situations, they're more of a burden to other people than they are in reality, and that might be something that is a driver of suicide ideation. All right, and so this paper is published here. We recruited people here oversampling for suicide ideation specifically, recruited 213 people. And our results are as follows. So first, this is a partial correlation network, and it's cross-sectional data. And what you can see here, just to orient you, is that the constructs from that BAID task are over on the bottom left, right? So NII is negative interpretation and flexibility, PIB is positive interpretation bias, NIB is negative interpretation bias. And the other things in this network are all theoretically important drivers of suicide ideation. So things like defeat and entrapment, which is SDES, things like hopelessness, which is BHS, and perceived burdensomeness, which is the thing we're really interested in, is burden over on the top left. And you can see that there is a pathway here connecting inflexible negative interpretations, then perceived burdensomeness, and then SSI5 over on the top left is suicide ideation. So we see that partial mediation pathway that we thought was going to exist in the cross-sectional data. But of course, that's cross-sectional, so we wanted to look over time. So we did this again, and sorry for the small text here, but we did this again looking at over the course of 3 weeks. So we looked at inflexibility at time 1, along with everything else, then looked again in the middle, and then looked 3 weeks later for the outcome of suicide ideation. And we see that mediation pathway again in the longitudinal data, and it's over on the left, the far left, which I've bracketed, and over on the bottom, which I bracketed. And that effect holds over time, it's statistically significant. So we see that reliably both in the cross-sectional data and in longitudinal data that inflexible negative interpretations are related to suicide ideation via perceptions of burdensomeness. Okay, so now I want to tell you a little bit more about some recent work that we've done really quickly, and I'm just going to give you brief overviews of all of this, but just to point you to what we've been doing. So one of the things that we're really interested in is trying to get something that might be a little bit easier cross-culturally to work with, because language is actually really, really hard to use to create ambiguity with across cultures. And so we wanted to do something that was useful for that reason, and also something that might be developmentally scalable. So we might be able to go to lower ages, and we wouldn't have to worry as much about reading level. And so we decided to try to make this task that is focused on pictures. And we start with ambiguous pictures, and then those progressively disambiguate, kind of in the same pattern as the bait task I showed you before. And this is one of the examples where, at first it might start off kind of negative, and it looks like maybe people are fighting, but in the end, it's that these kids are all focused on, celebrating something on their sports team, right? And so we constructed 2 kinds of scenarios with these pictures, positive outcome and negative. And you can see that they have this classic Bayes pattern where you start with something that is true in the end, but it's ambiguous to start. There are lures that start off as most plausible and become less so. And then there's absurd statements which kind of stay implausible throughout. So it has that Bayes pattern that demands belief revision. And when we actually start to look at the results, what we can see is that IFI, which is our inflexibility index here, is actually related to depression above and beyond interpretation bias, and it's also related to anxiety above and beyond interpretation bias. So we have this test that seems promising. We haven't done too much research with it yet, but it opens up a lot of possibilities in terms of population. Then we've worked with adolescents. These are adolescents in Israel who are completing both ecological momentary assessment to look at their actual day-to-day emotional lives interpersonally, whether they're fighting with people, generating tension, whether they're having positive emotional interactions with others, so like they're getting hugs from their parents, things like that, and also completing these Bayes scenarios. And what we end up seeing, interestingly, in these data is that inflexibility actually moderates the impact of negative interpersonal events. And so you can see that in the panels here on the screen. Depressive symptom severity is on the criterion axis. The negative event score is on the abscissa. And the negative event score is kind of the average amalgam of how many of these negative interpersonal events, like fighting with your parents, are happening to the kid on a daily basis. And then their depressive symptoms on a daily basis are on the other axis. And we split people according to their inflexibility. So pink is the highest, and then it goes down from there. And we see that inflexibility in the Bayes task, those people who are really inflexible, they are the ones who are kind of ending up with higher levels of depression symptoms when they're experiencing these negative events, right? Perhaps because they're ascribing more meaning to them, right? And when positive events happen afterward, they're kind of ignoring those, they're not incorporating that evidence, but also because maybe they're dampening their positive emotions even more when they're having these negative events happen. Right. So we see that in adolescents. 2 more things that are really just published. So these papers are 2024 and 2025, but both of them are coming out in the next couple of weeks. So these are some work trying to just narrow down a little more what is the effect of inflexibility, and they're psychometric network papers, all cross-sectional, so it's preliminary work. But the first one here is in a sample of individuals who have depression and anxiety, plus some general population people, what we end up seeing is that inflexibility is specifically related to general distress. And so it's not as much related to depression or anxiety specifically directly, but is related to this general distress kind of symptom cluster. And also it's very strongly, much more strongly than that, is related to detachment. So detachment is kind of both interpersonally, not being involved, and also a sense of detachment from life and emotion. And that seems to be something that's really important to kind of connects with this anhedonic phenotype. So that's our first network analysis. And then the other thing that we've tried to do is to look at whether this actually starts to matter for actual network structure. So does it change when you're more inflexible, the way that you're actually interacting with other people? And we don't really see strong effects with that. So people's subjective reports of how many friends they have, things like that, don't seem to be related to inflexibility. But negative interpretation of flexibility, again, here in this new sample, is related to dampening of positive emotion, this time co-dampening with other people. And that's kind of the strongest effect here that you see with the really bold line going from inflexibility. And then also we see some effects with things like excessive reassurance seeking, which can drive away friends and encourage depressive symptoms and anxiety symptoms. So we're seeing a lot of connection to things that might drive depression, but specifically the thing that really stands out again is dampening of positive emotion and co-dampening. So I want to just thank a bunch of collaborators here. These aren't all of them, but just to picture a couple who we've worked with over the years, and particularly Jonas Everhart, who wrote the original BAID task with me. All right, so thanks to everyone. And with that, that's my time, so I'll take questions.
Thank you, Dr. Bronstein. If there are any questions, please put them either in the chat or in the Q&A function. And I think I'll start with a question for you, Michael. So one way that you could frame biased interpretations is using a Bayesian framework. And I know in terms of psychotic disorders, I've seen different Bayesian theories that suggest folks with psychosis may either have differences in the strength of their priors or in kind of the weighting or the level of noise in their incoming sensory evidence. I wonder if you've thought about that in terms of kind of your work and how that fits into the kind of negative emotion space or internalizing disorders.
Yeah, definitely. So you're right. People with psychosis have these like over precise priors, and they might neglect some bottom up evidence, right? And with depression, we also see that there's some Bayesian belief revision issues, and particularly around valenced information. That's a lot of the work that Kubia's done. We haven't actually looked to see like what the specific deficit is in a Bayesian sense on the emotional BAID task. And part of the reason for that is we don't have enough trials. So it's incredibly hard to construct these scenarios, and particularly cross-culturally. So for example, like the kids from Israel, they just really do not get subtle social signals because everything in their culture is very direct, right? So if I don't like somebody there, I'm going to tell them, right? And so just, subtly saying like, oh, I'm busy, and never making plans, that might signal to someone here, hey, they don't like you, but that does not work for kids with Israel. So yeah, we have like 30 scenarios or so on the adults, and then another 20 on the adolescent BAID task. So we don't quite have enough to get the number of trials that you would need to get a good computational model of some of this stuff. The other thing that's kind of related to your question is we also haven't really gotten a chance to look as much at what the neurocognitive basis of this is. In schizophrenia, the BAID task, sometimes it's related, inflexibility there is related to set shifting deficits. So like the Tower of London task and the Wisconsin card sort, but it's not incredibly reliable. And different studies have gotten different results. So that might be different in depression, but that's a study we want to do that we just really haven't. So yeah, a lot more work to do in both those areas.
I had a question for you. So a lot of your work is kind of going from negative thoughts to can they shift to positive thoughts, and please correct me if it looked like on the screen positive to negative didn't have an association.
Yeah, so we have found that going from negative to positive is the most reliable across all of our studies, across different populations developmentally, right? and internationally too. Positive to negative is sometimes associated with all of these things because there is a common core construct of inflexibility, I think, that both these things tap into. But the positive ones are a little bit less reliable. That might be something to do with the quality of our scenarios. It could be that the negative to positive ones are differential in quality from the positive to negative ones, and that's very hard to evaluate. We think that's not true, but it could be. Or it also could be that there is a real emotion specific thing where inflexibility from a negative to positive direction really is the thing that matters. I'm not sure yet. We need to do more research to really figure that out. And you're right that you might expect that in fact positive to negative might be the thing that is really most important for people with anxiety and depression. But that isn't what we've found in terms of reliability.
The reason that I asked that is because my mind goes to bipolar disorder. So especially where a lot of people are, have depression, but when they are manic, they are really positive. And so that's kind of where my mind goes to on the inflexibility of not being like normally positive, but being grandiose almost. And does it work in reverse? Anyway, that's kind of where.
Yeah, if you talk to me in about a year, we should have some data with the 7 up, 7 down scales, and that might give you a little better idea, but we don't have those data yet.
Thank you.
Yeah.
So I was just wondering,
Yeah, so the question was whether the work that we've been doing can be translated into intervention, and if so, how that would happen. So I think one of the things that I would really love to be able to do is to use this in 2 different ways. So one is for selection of individuals into intervention. So I think that individuals who are more inflexible on our task should actually have more trouble with interventions for depression that are meant to upregulate positive emotion just because they're already starting with this propensity to dampen and to co-dampen. And so specifically behavior activation paradigms might be less effective for these individuals who start out with inflexibility, and remediating that, right, with neuromodulation or something else might actually be helpful for these individuals as a pre-treatment. So that's a study I'd love to do. It is hard to get a large sample of individuals who are going through the same standardized treatment, so we haven't done that yet. I think to get reliable effects, we need like 200 folks or so. But that is a study I'd really love to do someday. And I think it could also be used as a marker of progression in CBT generally, in that if individuals are hopefully progressing well, they should become progressively more flexible, and that's a target mechanism in CBT, right? And that also might be like an early warning sign. If I go through all the thought challenging modules and things like that in CBT, and I'm not seeing changes in flexibility in social situations, that might be a sign that I need something else as adjunct. But all that untested, haven't done that yet. But we do think this has some implications in the clinic, and it's fun for people to do. So they enjoy it. They think it's like a cool puzzle, and even the kids are really willing to do this task. So that is an advantage in terms of making it something that could make it into the clinic someday.
We have a question from Lydia Zalowska on Zoom. She says, thank you for your talk. Can you clarify if you understand inflexibility as a state, depression or anxiety dependent, or as a trait, genetics, temperament, developmental?
Yeah, that's a great question. So cognitive inflexibility in general, right, it does have some trait-like qualities, right? There's test-free, test reliability, but it also does fluctuate with symptoms. So people, as they get more depressed, for example, they might have more rumination and things going on that challenge working memory resources, which you need for inhibiting your initial intuitive ideas and changing them into something that might fit the situation better according to evidence, right? So we do expect that there is some state dependence, right? But we've generally looked at a kind of more trait level, right? And at least, across the past month, what are your symptoms and how does that relate to inflexibility? Looking at state is really hard because, again, we're limited in the number of scenarios that we have. It took us a year and a half to make these originally, and again took us a year and a half to do it with the adolescent task. So getting enough scenarios to be able to do different tests over time with individuals as they fluctuate across states has been very, very difficult. And even making test equivalent forms with what we have in terms of scenarios has not worked out the best because we spent a lot of time trying to do that. So, someday, hopefully we can look more at state. But I think that we need somebody to sit down and generate a lot of scenarios. Maybe we need to pay some creative writing students for a while, but that's some work for when we have a little bit more time and resources.
I think we have time maybe for one more question from Rochelle Moen on Zoom. I do have a question regarding application to clinical work. I work with BPD patients in DBT. The focus often is the patient's all or none thinking with the skill of finding the middle path and or resolving the dialectic. It seems that this addresses the importance of more flexible thinking. Any other strategies recommended?
Yes, I think this does address the importance of inflexible thinking. I agree. It's a great medium, to talk about inflexibility and why it might be problematic with people. So, for example, like in schizophrenia research, there's metacognitive training, and they actually go through some of the BAID scenarios from the original BAID task, and they've drawn them out so they have pictures to accompany them. And they talk through, oh, look, we might really get things wrong if we just stick with our initial belief. And what are the consequences of that? Might we, have an emotional life that's really different if we do that versus if we don't? So that's been done for schizophrenia. MCT for depression is also being trialed, and the data preliminarily look good, right, for changing some of these cognitive biases. So I think the data are good enough that, you could use this as a medium for talking about inflexibility in social context with a client, and particularly something like borderline personality disorder, where there are such central interpersonal concerns. It might be a really great medium to do that because it's really tailored to that. But in terms of using it as a testing medium and trying to select people for treatment or things like that, we don't have the data to do that responsibly at this point.
Let's all thank Dr. Bronstein again. Then we will transition to our second talk in the series from Dr. Katie Cullen. Dr. Cullen is a full professor and the head of the Child and Adolescent Mental Health Division in the Department of Psychiatry. She received her bachelor's degree in history, philosophy, and social studies of science and medicine from the University of Chicago before coming here to the University of Minnesota for her medical degree, residency, and internship. Her program of research examines the neurodevelopmental underpinnings of depression, self-injury, and suicide risk in adolescents and young adults. And she also does work testing the efficacy and mechanisms of novel interventions, such as neuromodulation, pharmacology, and creative arts-based approaches to promote recovery and thriving in these youth. And the title of her talk today is Imagination Studio, an Arts Intervention for College Students with Depression. Let's welcome Dr. Cullen.
Thank you. Great. Thanks for inviting me to talk about this project that was supported by a grant from the president of the University of Minnesota. It was called the President's Initiative for Student Mental Health in combination with MIDB put out a grant that we received. And so that's what the project I'll be talking about today. Most of my career I've focused on depression in young people, mainly adolescents, and more recently, young adults. So as we recently heard from that excellent talk, depression can be, a very serious problem that needs to be understood better. Especially when it emerges young, there can be severe consequences, including chronic depression, disability, other health problems, and suicide risk. And the treatments we have aren't always effective. And so we need new strategies. So I'm not going to tell you the whole story of our creative arts work, but the jumping off point for this project is a study that we did previously called Creativity Camp. And this was a project that was focused on adolescents with depression. Basically, we offered camps over 2 summers, and this was a 2-week intervention. It was extremely fun, and I'll encourage you to read this paper we just published in the Child Psychiatry and Human Development Journal. which I'm the first author, and Yuko Taniguchi, pictured on the right with me, is the senior author. And she's the person who designed the curriculum of Creativity Camp. And you can see a bunch of us, including Dr. Mueller, at the Weissman Art Museum at our celebration event. So anyway, we had this project called Creativity Camp. It was really fun and successful for teens with depression. And because of this, we began to wonder about other populations, specifically young adults and specifically college students. Could this be effective for? So I mentioned depression is really important to study in adolescents, but pretty important in young adults too. In 2018, a paper by Randy Auerbach and colleagues reported that 31% of college students around the world reported a mental health problem, and that was before COVID-19. Colleges and universities are overwhelmed, and they are not able to meet the students' mental health needs, and that includes the University of Minnesota. And so there's a need for alternative treatment. So this was the space in which we started our project. Several years ago, I had the opportunity to meet Alejandra Pena. She's pictured at the top, who was stepping in as the new director of the Weissman Art Museum. She'd learned about our Creativity Camp work, and she was really interested. And she just said, "We have to do something for our students." And we were able to partner with her, bringing in some of the group of people that had been working together with on Creativity Camp, including bringing in some of these people at the bottom from Boynton Health and from the college student counseling services. And then we also brought in Maren Olsen from the medical school, who helped us bring in medical students to help volunteer on the project. So it was a very interdisciplinary collaboration to work on this project funded by the PRISM initiative. And here were our research questions. Is it feasible to implement an arts intervention for undergraduate students with depression? That was one. Some of our colleagues, especially the professors over on the undergrad side who are working with students, really weren't sure if they would do it. These students are stressed. They're not going to have time to add one more thing. So that was one question. How might an arts engagement impact mental health and well-being in this population? Would we see something kind of like what we saw with the teenagers in Creativity Camp? And we wanted to explore mechanisms, and there's many possible mechanisms. We don't know what the mechanisms are, is sort of the spoiler alert, but we wanted to explore some potential cognitive mechanisms by which arts engagement might lead to improved mental health and well-being. And we had this idea that maybe it was something about cognitive flexibility. So somehow engaging in the arts would inspire different ways of thinking and promote cognitive flexibility. So this is a very nice connection to the talk that you just heard from Dr. Bronstein. So this was just a pilot study, basically a prospective cohort study, no control group or anything like that. We did 6 classes. We decided this was, again, kind of some things were done to be feasible as this first step with college students. We only recruited college students, and they had to have depression symptoms. So this was the sample. They had to be undergrads at the University of Minnesota. We offered 6 classes, and this all occurred in the fall of 2023. We had 2 options. One was at the Weissman Art Museum, and one was at MIDB in the large conference room. So they're both very kind of beautiful settings in which to offer the class. We did a bunch of different assessments 3 times, one before the intervention, one after the intervention, and one 6 months after the intervention. And I'll tell you what they are in a second. And then finally, we had an arts exhibition to celebrate the art and the artists at the Health Sciences Education Center, which, if you haven't been there, is beautiful. And they created this beautiful space to display art before we collaborated with them, and our grant helped to expand it. So I'll show you a couple of pictures of that. And that occurred in spring of 2024. So I was about to say something about the assessments, but now I forgot what it was. Maybe it will come to me. So first, in terms of measuring mental health and well-being, we used the mini kid to just diagnose our sample, but we didn't require any kind of diagnosis. We just required that they had depression symptoms that were identified at the time of screening. And so then we measured at the 3 time points, we measured depression severity, anxiety severity. We also measured affect, and we had 3 measures of well-being: flourishing scale, satisfaction with life, and zest for life. In terms of the cognition, so we had creativity, performance, and flexibility. So our one assessment of creativity for performance that we used in this study was a measure developed by our colleague in psychology, Wilma Kutz-Stahl. It's called the Figural Interpretation Quest. And we really like it. We used it in the creativity camp. Oh, I know what I was about to say earlier. We did not do brain scanning in this study. We did brain scanning in creativity camp. We didn't do it in this study, but we did a few cognitive assessments. So this figural interpretation quest, we had seen a signal from our creativity camp that the kids had got more original in their thinking after the intervention. So we wanted to use this. And this is just an example, but they see kind of these colorful, ambiguous figures, and they have to imagine what it might be. So if you're familiar with the alternative uses task, it's kind of like that, but like a little bit more fun. And I don't know, it's different. It's more visual. Yeah, so they make up different things and they kind of come up with as many things as they can, and they're told to be creative. And then those things their responses are coded for originality, flexibility, and fluency. And then we also used an automated computational approach called semantic distance, which just measures the distance between the responses and of the words. And it's a way to assess, it's correlated with creativity performance. Okay, for our cognitive flexibility task. So first of all, we had a self-report questionnaire called the Cognitive Control and Flexibility Questionnaire. And we had 2 behavioral tasks. One is called the task switching, which is they're classifying numbers and letters in these different contexts. And then we had the trail making task, which also involves switching between numbers and letters. We had these 2 task switching kind of cognitive flexibility assessments. Again, they did them 3 times. The intervention, I don't have a ton of time to go through all the details, but I'm happy to answer questions about it. So this was 6 classes. They each were 2 hours. They had different art projects. These art projects, generally the activities are kind of designed to guide, to promote self-inquiry, and to be fun and to be inspiring. So we actually also had a Minnesota State Arts Board grant. So that allowed us to pay artists to come in and work with our students. So these are all, at the bottom, I've shown all of the artists that we brought in. We wanted to bring in artists from different communities to be inspiring to, if our group of students who might also come from different backgrounds and communities, and they all had different kinds of expertise in terms of their arts. So, and then we also had a bunch of students from the University of Minnesota leading the class, so that they were all trained to just support the class, and they're shown at the top right. So we had a bunch of staff and students, undergrads and grad students, including medical students, supporting this study. So this is probably hard to read because there's a lot of things on here, but this is just a description of our participants. So we had 28 people that completed. Here you can kind of see this is the sex at birth, mostly female at birth assigned in this sample. And this is not a large sample also, but this is so that we had 25 female at birth. And then we did have a little bit more gender diversity in terms of gender identity. In terms of race, predominantly white, and there is the second most racial group would be Asian, about 2/3 upper and middle class, either upper or middle class of this sample. And all of the all of the participants did have at least one mood disorder. They didn't all have current major depression, but almost all of them had major depressive disorder at some point. They carried that diagnosis, and one person carried bipolar disorder. The others had, there was a fair amount of anxiety and a smattering of other diagnoses. So that's our sample. Here's what we saw with changes in mental health symptoms. Again, don't have a comparison group, this is, must take it with a grain of salt, but this is encouraging. We saw a significant drop in mean depression symptoms and mean anxiety. We were mainly interested in depression, but we thought might as well look at anxiety too. And we did see significant changes at the post-intervention assessment, and those we saw actually similarly low symptoms at the 6 month. So that was, and I would like to note that this, since they all had the intervention in the fall, you might imagine that their depression and anxiety would be worse at the post-assessment because it was right before finals. So that was, we were really worried about that actually. We were like, we're not going to be able to show a decrease in depression and anxiety because this post-assessment is like right before finals, but we still were. So that was a very good thing, and that was reassuring. We also showed increases in our well-being measures, all three of them. So that was good, that were significant, and that sort of stayed similarly high at the 6 month. In terms of our cognitive assessments, we did find evidence of improved scores in our cognitive flexibility. And in terms of the creativity assessments, the semantic distance was significantly increased. Actually, the originality wasn't significantly increased, but the other two hand-coded ones were, the fluency and the flexibility. And then generally these like improvements were sustained at 6 months. So I'm giving like a really brief overview because these data get a little bit detailed and in the weeds, but we were able to see some improvements. I would say improvements because this is like, we don't have a comparison group. So it could be, whereas you don't really have practice concerns with a PHQ-9 repeating it, you do have practice concerns with a cognitive task that you're taking multiple times. So, but on the other hand, again, there's interesting aspects to this data, at least it's going in the right direction. So be that as it may, these are the things we're seeing. We were really interested in, does improvement in cognition, creativity, performance, flexibility, is that related? Like, is there a correlation between the amount to which they improved in their cognitive functioning by these measures relate to their the amount to which they were like improving in their mental health? And we didn't really see that. So I would say most of our correlation analyses were not significant. So I guess we can say this intervention seemed to lead to increases in mental health, and it also seemed to be associated with some improvements in these cognitive measures, but that we didn't have strong evidence that those two things were correlated. Okay. We did an arts exhibition at the Health Sciences Education Center, and it was really wonderful. Here's some of the artworks that were on display. This is actually this is just a screenshot from the website, which is down at the bottom. So these artworks were on display. We had a beautiful event. Then they were on display for like the entire summer, actually. And it was just like a really nice way for the students and the families to be celebrated, to talk about mental health, to talk about creativity in the arts, bring people together. And this is something that we've tried to do in all of our different creative arts intervention studies, and it's always been really, really important. So I wanted to highlight that. So to conclude, Implementing an arts intervention for college students with depression is feasible. We did find we had very high retention rates, so we didn't pay them to come to the sessions. Actually, we did pay them to do all of their questionnaires and their cognitive tasks. We didn't pay them to come to the art sessions, but they came to the art sessions for the vast majority, except for maybe one or two when they were sick. And nobody dropped out because of finals or something like that. We found preliminary evidence for positive impacts on depression and anxiety and well-being and creative thinking and cognitive flexibility, with the caveat that there might be practice effects. Although I'm not sure if you can have practice effects for a semantic distance measure of your responses to how what a colorful blob might be. That's something to think about. So future, I think one of our take-home points is future work is needed to looking at larger samples. This was a small, preliminary step with randomized control designs that include an active control condition to confirm efficacy and identify mechanisms of action. So maybe we would look again deeply at flexibility. Maybe we should do something like Michael Bronstein and look at like interpretation flexibility or something like that. Or maybe there's some other mechanisms that would be more of interest to study. I would like to thank my group. Not all of them are pictured here, but a few people. This is us advertising for the study at the Weissman Art Museum. The Weissman Art Museum has been a really wonderful partner for a lot of our projects. Support from the National Endowment for the Arts and Minnesota Arts Board, in addition to, as I mentioned, the Minnesota President's Initiative and MIDB. And I will stop there. And early, plenty of time for questions.
Great, thank you, Dr. Cullen. I have a question to get started. And if there are any others, again, please use the Q&A function of the chat on Zoom. So Katie, one thing that I'm thinking about is a possible barrier for participation that I could imagine for someone who's thinking about enrolling in this, like, so let's say you scale this up, is someone saying, I'm bad at art, I don't have the skills, I can't do this, or alternatively, I don't want people to judge my art, I don't want that kind of stress, or I imagine that this could lead to some selection bias or just kind of a barrier to participation in this as a therapeutic approach. How have you thought about strategies that address that reluctance or that fear or that kind of fear of judgment?
Yeah, that's a good question. I don't think we did much upfront in this particular study to alleviate that. We do this particular intervention. I mean, it's different from like enrolling in an art class in which you're going to be getting a grade and you're going to be judged on some kind of mastery of something. This is the focus of these arts interventions that we've been delivering is more about tapping into what's true to you. And if you are expressing what's true to you, that's the only right answer. And so celebrating, like kind of recognizing everybody has creativity inside and just engaging in activities and that can be maybe successfully tap into that and celebrate it. So I think in practice, it works, but I don't know that we've articulated a way to, reassure people up front. And I think you're right. There is a selection bias that people will be more likely to sign up if they're like, oh, I like the arts. I know I like the arts, at least in this study. In our creativity camp study, it was different because the parents are the ones. So there might have been some parents saying, oh, I know my kid likes the arts, so I'm going to sign up my kid. But there was definitely parents that were like, you're doing this. And it wasn't necessarily because they were interested in the arts, because they just wanted their kid to have something to do and they were concerned about their depression or something. So I think it varies across samples as well, but it's a great consideration and an important one. Yes.
Oh, thanks. This is really wonderful. Thank you for running this intervention. I had a question about, so 6 months later, their scores are very similar, which is, yeah, quite amazing. But I was wondering, did some of the students, did they carry on doing art in that time? And is that why their scores remained lower, or do you not have that
Oh,
data?
that's an awesome question. We interviewed them at 6 months and we asked them kind of detailed questions about that. And I think we're still analyzing that data. So I don't actually know offhand, but I believe the answer is yes, to some extent. And both for actually for Creativity Camp and for this study, we're kind of we collected a lot of we did a lot of qualitative data analysis. So we like wrote observations, we documented notes at every session, we did interviews. So all of that is forthcoming. And I think that'll be really interesting. Thank you for that question. Yes, Caroline.
Thanks. I had a similar question about if you know more about what the participants' other access to treatment was, and if that changed over time, because I would imagine that maybe one mechanism of action is becoming more comfortable being vulnerable and having that introspection, and that might actually yield more willingness to seek other treatments or support. So I'm just curious about that aspect. So maybe something else to
Absolutely.
keep looking into.
We definitely, I think we had that in our qualitative and interviews. Like we had the same idea, like, could this be an entry point for some people? Like maybe I could talk more about what's going on with me after having this kind of experience that is maybe felt initially a little safer than going to a clinic. Yeah, thank you. Yes. All right.
You
Hello? Oh, hi. Okay. So I was curious, were you looking at any interpersonal factors, I guess in this study and in the creativity camp as well? Maybe these people were like building more interpersonal bonds without judgment. And I was just curious if you included any of that in your measures.
That's great. Yeah, we didn't. We have since incorporated I think it's probably one of the key mechanisms is just, I really think that being in a group where you are it's kind of a beautiful setting for making connections, because you're in a group, you're in this like studio setting. It's not a classroom, but there is some structure, but you can just you're kind of doing your own thing. You can interact, but it's not like constant, and you can kind of have meaningful conversations, but they're not structured. So it is actually a really special way to connect with others. I think we have started collecting some data with a measure called social connectedness. We have a couple different social connectedness measures we've used in a couple of our projects. We didn't use it in this one, which I feel sad about. But even that, like, it's just a questionnaire. So, we did have some sort of observations about connections, but that's also not quantitative. So I would say we're still searching for the best methods to quantify that, but I think it's probably one of the most critical aspects. Yes, one piece of the puzzle at least. Yeah. Okay.
When I think back to undergrad, I think about there's like three major people, like you're really high achievers, you're kind of average people, and you're people who are just kind of happy to be in the school. And then with those personalities, I also think there's like, type A people and people who are more relaxed, and they could be scattered too. I could see those things potentially impacting someone's results in the program. I was wondering if there's any thoughts to look into that for future studies.
Like the extent to which somebody is like type A versus type B or something.
That, and then just like if you're a high achiever, like everything, like for me, like in college, like everything was to be done at a certain level so it could get me to that next step, because like college wasn't where I wanted to stop necessarily. But I had friends who college was where they wanted to stop, and there wasn't anything wrong with that. But so they were viewing things through a very different lens, where it was more just like, I'm going to do this class and have fun. Whereas like in my mind, it would be, I'm going to do this class and I will have fun and learn something, and it will also go on my resume, and I will perform at this level in the class, even if there wasn't a grade associated with it.
Mhm.
That's kind of,
Yeah, I think it's a great point. I think that college, I mean, the situation of college is so, I mean, young adulthood as a developmental stage is stressful, but college itself is incredibly stressful. And yeah, and people interact with it in different ways, depending on their personality and their expectations that they have for themselves, or what people have for themselves, or, you know, their parents have, or something like that. Personally, I was so stressed during college because I was trying to make sure I had good grades for medical school. And I'm not sure that I would have, you know, yeah, like, yeah, I totally see what you're saying. Like, it's, you know, is this going to help me achieve my goal? It's a great point. Thank you. Yes, Lionel, did you have a? Yeah.
Place of employment at once, and you were able to ask adolescents to do something similar. Because what you would expect to draw their depression, lots of clouds, darkness, and a very kind of sad discord, which is not at all what I see in the word. So wondering if and perhaps how you frame the artists was a very different operation than depression, or whether all have depression.
That's a great question. And I, okay, and I realizing I'm running out of time as well. So the question was, the artwork that I'm showing is like happy themed, first of all. And then how did we frame the sessions? Because they weren't, and I'm so glad you raised. So first of all, I probably had a bias in what artwork I selected for this presentation. There were definitely some really dark arts that I didn't like highlight, because maybe that doesn't like convey my theme of it works. But about the other part, which is I think really important, this isn't therapy. It's just not therapy. These aren't art therapists. They're artists, and their instruction when we've talked to the artists and how do we want this session, the goal isn't at all to talk about mental health. It's literally focused on their creativity, their way of expression. And it's not even about necessarily technique, although they do learn some techniques because they're being taught, they're given projects, but it's more about like, how can you get that authentic expression? And so I think that is, but the kids in creativity camp did voice that they appreciated being in a group of kids where they knew everybody else had depression, and that they could feel safe talking about stuff. But it wasn't like a typical group session for depression, if you know what I'm saying. So that's one unique thing about it. With that, I'm going to end because we need to reserve time for Dr. Quevedo. Thank you again.
Thank you, Dr. Cullen. And so our last final speaker will be Dr. Karina Quevedo, who is an associate professor in the Department of Psychiatry and Behavioral Sciences. She completed her PhD at the University of Minnesota Institute of Child Development and her postdoctoral training at the University of Pittsburgh Western Psychiatric Institute and Clinics. Prior to this, she received her bachelor's degree in psychology from the University of Havana in Cuba and a master's in counseling psychology from the University of St. Thomas here in Minnesota. Dr. Quevedo's research interests span typical and atypical pathways of emotional development, brain, physiological, and hormonal markers of child and adolescent adaptation, and the long-term impact of adverse experience and adolescent psychopathology. She has additional interest in neuromodulation approaches for treatment-resistant depression and suicide attempts in youth and adults. And her talk today is entitled Right Amygdala Real-Time fMRI Neurofeedback During Self-Processing for Borderline Personality Disorder. Thank you, and help me welcome Dr. Quevedo.
Thank you.
So thank you for having me here. This talk is going to be quite data heavy because literally all of these results are just out of the oven. We finished our analysis last week. So I apologize for the lack of reflexive interpretation of the results because it's a little bit raw. So I welcome any questions afterwards about that. So okay, so let's see, does this work? Huh. It's not responding. I apologize. It's not moving the slides forward. Oh, here we go. So borderline personality disorder, as many of you might know, could be, and this is entirely my organization of how to think about it, could be organized in two large constructs, more or less. One of them pertains to self-related symptomatology, many of which are particularly unique to this disorder, including dissociation, memory lapses, detachments from reality, and detachment from the self. And we know that this is also accompanied by a distorted self-image. So individuals with borderline personality disorder not only have this abnormal integration of the self and their memory, they also tend to have a particularly negative and unstable view of their own sort of structural internal personality and who they are. They also exhibit another cohort of symptoms that can be broadly gathered around a theme of emotional instability. But importantly, both of these domains, distorted self-image and emotional instability, are associated to repeated suicide attempts, and they appear to be predictors of suicide attempts via what appears to be different path, but my data may suggest that this is actually a joint machinery that is underneath both sets of constructs. And then just to kind of highlight the other kind of difficulties that borderline personality disorder exhibits, they also are extremely impulsive. They have intense fears of abandonment, particularly with regards to attachment figures. They have unstable, extremely volatile interpersonal relationship, and they also engage in self-harm. Borderline is actually extremely expensive. It's associated with twice the costs of depressions. And while we have therapies that are relatively successful at treating borderline personality symptoms, at least in the short term, such as dialectical behavioral therapy, cognitive behavioral therapy, and psychodynamic approaches, recent meta-analyses have shown that the effect sizes and the duration of the effects of the treatments is relatively modest. So even though it helps about 50 to 35% of the patients, what the science seems to be finding out is that afterwards the effects are not very long lasting. So what we're hoping is that we can come up with different ways of essentially treating this highly burdensome disorder by maybe bringing in new tools to our tool set, specifically neurofeedback treatment. The data that I'm about to present specifically targets neuromodulation of the right amygdala using endogenous mechanisms with the goal of modulating and changing the implicit emotion regulation circuitry, and then also basically the basis of implicit self-processing. I took some slides out in order to go a little bit faster, so I'm happy to talk about later what do we mean when we talk about implicit self-processing. So let's talk a little bit about the circuitry. So we know that amygdala circuitries are functionally connected to midline cortical structures that support emotion regulation and self-face recognition. And that is what our research seems to have basically shown. Amygdala circuits for self-face recognitions are also a biomarker of depression, basically being depressed versus non-depressed, of suicide ideations, of suicide attempts. And higher amygdala connectivity during neurofeedback paired to the self-face turns out to be, at least in one publication that we recently got out, associated with as a biomarker of improved depression. And interestingly enough, lower right amygdala connectivity during neurofeedback, also paired to the self-face, is a biomarker of suicide attempts. Again, this is somewhat of a cohort of results that point us toward this circuitry that when you put basically you join the dots together and a hypothesis might emerge about the importance of this particular circuitry. So what about amygdala circuitry and borderline personality disorder? So both activity and connectivity of the amygdala to cortical areas is linked to emotion dysregulation, particularly aggression and anger, as well as suicide ideation. So our aim is to modify amygdala circuitry underlying positive self-processing in borderline personality disorder, and specifically to engage the same networks that support abnormal self-processing and related symptoms such as emotion stability and suicide ideation. So hopefully to revert or to reorganize, to normalize this circuitry to improve some of the core symptoms of borderline personality disorder. So why the right amygdala? Because behavioral, imaging, and lesion studies appear to coalesce on the idea that the right amygdala is the central hub of a system of automatic saliency and implicit emotions, basically the kind of stuff that we are not aware of, our implicit inner emotional life. These areas are profoundly engaged by imaging material, visual stimuli that are processed fast, that are basically linked to holistic impressions of ourselves and others, and that are related to global emotion-related stimuli. So it's a way to get our subconscious machinery. I've always been sort of fascinated by implicit processes because those are difficult to get hold on and to basically treat or study. So that's why I'm interested in the right amygdala. So how was the study organized? So this was somewhat of a longitudinal study by default because we had to do this in the middle of the pandemic, just like Katie. So we had an initial first visit where they were psychologically characterized, followed by 2 scanning sessions during which they received right amygdala neurofeedback. There were also other tasks pertaining to self and other recognition and emotion regulation that were administered before and after the treatment, but we don't have the results for those yet, so hold your horses about that. And then we followed up 3 weeks after the last intervention, again with psychological assessments. We just concluded a 6-month follow-up online for these patients, but we don't have that data yet, so we'll have to wait for what happens 6 months after the treatment. Hopefully they are doing even better than 3 weeks after. So this is our sample composition. These were primarily females, which is usual for borderline personality presentation that comes to clinical settings. They were primarily of lower SES. As you can see, the income brackets here were not very high. They were young women, college-age women. And also, as you can see, they were predominantly white, and they were fairly severely presentation of borderline. The baseline BPD score that is sort of a moderate levels of symptoms is about 35. So our mean is quite high, which gives us confidence that this individual's presentation was definitely within the clinical range. These were not sort of at the lower end of the distribution. They were definitely sick. So they were asked essentially, as I mentioned, to describe their symptoms and their presentations on the first visit. And then the typical lineup of the second visit would be a recollection of 5 salient happy memories. And we would help them to identify basically the peak moments of the events. And then they would use those memories to modulate their right amygdala activity inside of the scanner. And this is sort of the summary of the conditions that they would see inside of the scanner. As you can see, they had 2 key conditions. One of them is the neurofeedback conditions. They would see their own smiling face, and then a bar of changing color that you can see the little green bar there that would go up if the activity was above 0 and down and become red if it was below 0. And then the control condition, and this is a sort of a hot topic in neurofeedback, we can talk about that later, is the best that we can do, which is basically to be seeing a different face to purportedly engage the same circuitry of face recognition, which is very prioritized in humans, and then count backwards, which is a working memory tasks that hopefully engage some of the same frontally mediated areas that pertain to memory recall. And that was the best, basically, counter condition that we can find. So they received 2 days of treatment, which was really a gift to be able to do this for so long. And I'm very happy that we were able to do it this long. So again, this is a recall of the study timeline, and then let's start and look at some results. As I said, this talk is going to be very data heavy. So fortunately, we were able to engage the right amygdala, which I was very concerned about, because it's an area that is not easy to modulate because we don't have a lot of access to it consciously. And we also, as you can see very prominently, the left amygdala was also engaged. And I'm not surprised about that, because that's sort of the voluntary lever between the two amygdalas. And this is our first day. And then in our second day, you can also see right amygdala engagement here and left amygdala engagement. And this is, by the way, whole brain level analysis. So which is, this is when you go to Vegas and you're very happy that this thing's actually worked, because I was concerned that we were not going to be able to engage it. So what would we expect to do in terms of network-wise? So it turns out that the non-coincidentally, the neural basis of self-processing and emotion regulation, they're highly overlapped. Very much the same structures, with very few exceptions, are sustaining both kinds of functions. So usually in self-processing, we have the posterior and anterior cingulate cortex, the amygdala, insula, and then areas of the medial prefrontal cortex. And similar areas are also engaged, by emotion regulation. So we found out that the same areas were recruited by neurofeedback. It was by no means just the amygdala that was called upon action to solve this task. And you can see that all of them, this is again, whole brain level analysis, all of them were engaged during the first day. And there is our amygdala again, our right amygdala. And then they were all primarily engaged during neurofeedback versus count backwards, with one exception on day one. And that was the precuneus. I was curious about that. I don't know why that happened, but that is just what happened. So here's the second day. Again, we have that very broad emotion regulation network engaged, and the right amygdala also showing up, which makes us all very happy. And all of them were primarily active during the neurofeedback condition, which, if you recall, is paired to the self phase, happy memories, and the changing bar of color, versus count backwards, which is our somewhat clunky but somewhat effective control condition. So the good news is that target engagement was accomplished, which is always a bit of a challenge in neurofeedback. It doesn't always happen, and it's very sad when you don't get target engagement, because it's so expensive to do this. And then here we have basically our activity levels, specifically for the right amygdala, very prominently positive during both day one and day two. During neurofeedback versus count backwards, the amygdala is in red, and the count backwards condition, which is the contrast condition, is in blue. All right. So what about symptoms? Did they get better? They obviously enjoyed that getting into the scanner for that long. They generally had good experience, but did this have any kind of long-term positive effects? So the answer is, even though this may seem very tiny, in fact, this is a significant effect. So total borderline personality symptoms improved over time, even 3-4 weeks after the last neurofeedback treatment, which is woohoo. You can kind of be happy about this, even though it seems so small. The other thing that improved were symptoms of dissociation, which is also unusual. So between the first and the fourth visit, dissociation was reported to be lower in these participants. Again, we don't have a control group. But at least this is a happy signal to depart from. They also reported less fear of abandonment in the fourth versus the first visit, and their capacity to accept emotions over time also improved. Individuals with borderline personality disorder are constantly fighting to accept their own emotional states, and as you can see, over the course of the fourth visits, their non-acceptance of emotions went down. And then also the part that was particularly happy for us was the fact that suicide ideation improvement was also noted in this sample. And this was both self-report and interview-based measurements, but I decided to just show you one of them. So is any of this associated with brain activity or connectivity, which is the next question? Is this just an effect of placebo, or there's some signal in terms of association of brain behavior associations here? Again, to remind you of the timeline, what I'm going to do first is I'm going to show you the results of symptoms change, which pertains to subtracting basically symptoms in session 4 versus session 1. And that means that higher numbers are essentially what we want to see, because that means that what we're subtracting is smaller than what we're subtracting from. I know that is complicated, but just keep it in mind. Higher numbers is better. And then we're going to associate that with activity and right amygdala connectivity. So we found that basically lower impulsivity from baseline to follow-up visit after neurofeedback is linked to higher activity across 2 days of neurofeedback with the thalamus, precuneus, cuneus, and posterior cingulate. All of these areas are engaged in the same big network that gets activated during neurofeedback. Similarly, you can see it here. This is a little bit easier to see it in terms of the association of impulsivity improvement. And again, this is activity during 2 days of neurofeedback. So we averaged the activity maps across the 2 days. We also noted that executive functioning improvement is associated with basically engagement of the midbrain, cerebellum, insula, postcentral gyrus, inferior parietal lobe, medial and superior frontal gyrus. Again, all of these areas, with the possible exception of the midbrain, is engaged during the neurofeedback versus the count backwards. So again, this is the same areas so that you can see the association between improvement of symptoms and engagement is a positive and clear relationship there. There's a lot of areas, so this required 2 scatter plots. So what about connectivity, right? So this is basically right amygdala connectivity association to symptoms improvement. So we found that less anxious attachment after neurofeedback was linked to higher right amygdala connectivity with the calcarine occipital lobe, superior middle temporal gyrus, lingual gyrus, fusiform, and caudate. I think the only area that is not engaged here during neurofeedback is the calcarine and the lingual gyrus, but the rest is clearly part of the same network. And these are basically the scatter plots that pertain to those associations between brain and symptoms improvements over time. So we also noted that overall BPD symptoms improvement was linked to right amygdala connectivity during neurofeedback, specifically right amygdala connectivity with the superior and middle frontal gyrus, anterior cingulate, and caudate. I was very happy to see that the anterior cingulate was part of this specific change in symptoms. This was something that I essentially predicted, but I'm glad that it became true. And then this is basically the same picture, but now shown as a scatter plot of borderline personality symptoms improvement associated with connectivity scatter plot for each of the areas. And then this one we couldn't fit in the prior one. You can see that this is quite new. So we fit it in a different graph. And again, this is the association between improvement in emotional acceptance after neurofeedback, and again, right amygdala connectivity on second day of neurofeedback. I'm going to try to go a little bit faster so that I can give time for questions. So the other aspect that improved was emotional awareness, which I showed you early in the symptoms change. And that was associated with higher right amygdala connectivity with the middle superior temporal gyrus, insula, and inferior parietal lobule. We can talk about the functions of these areas later if you wish, but for now it's a little bit, as I mentioned, a bit data heavy. Here is the scatter plot, again, showing the association between symptoms improvements and connectivity over time. And then we also found that improvement in in executive functioning after neurofeedback was associated with higher right amygdala connectivity to the middle cingulate gyrus. Here is the scatter plot again. And so just sort of to summarize, first of all, we found that high right and left amygdala engagement was basically confirmed during neurofeedback, that both increased neural activity during neurofeedback and increased right amygdala connectivity to cortical areas were linked to multiple borderline symptoms improvement. And then the future directions that we would like to pursue. First of all, we would like to look at specific associations of amygdala activity labels to symptoms change. We would like to explore activity and connectivity analysis on pre and post neurofeedback tasks that tapped into self-processing and emotion regulation. And also we would like to look at the left amygdala activity links to symptoms change, because if the left amygdala is a better predictor, perhaps I should switch my target. And I would like to also know what areas are common to day 1 and day 2 of neurofeedback, because they're not exactly the same. And then finally, some kind of long-term directions that I'm acutely aware of is the need of having a placebo or control group, because this could all be due to the fact that the scanner is a fancy machine and that everybody expects to get better after this. Hopefully that's not the case, but we would have to prove it. And I would also like to be able to not use explicit strategies, but also allow the individual to choose some of their strategies so that we don't necessarily add more burden, cognitive burden during the tasks. Some individuals found the whole memory recall to be somewhat burdensome. So they resorted to things like just anticipating happy oncoming events, or just repeating something like I'm happy and happy, like a mantra inside of the scanner. So this work was extremely labor intensive and very difficult to do during the pandemic. So I want to thank you to all of my team, and also to thank the Alternatives for Educational Initiatives Foundation, who basically founded our research. And now I'm open for questions.
Thank you, Dr. Quevedo. If there are any questions in the room or on Zoom, please let us know. Happy to get started. I'm struck, Karina, by how much of the functional connectivity results are highlighting the visual cortex. And obviously this is a visual task. They're engaging in perceiving either their own face or someone else's face. And I kind of wonder how you think about this in the context of the neurofeedback literature, which I certainly don't know. The kind of sensory modality that is being used for the input to the neurofeedback process, kind of whether that is changing the weighting with the target between the kind of early sensory areas or kind of sensory association areas and kind of visual networks, and then that right amygdala target. Is it that kind of network relationship is getting either strengthened or altered in some way? I'm kind of interested in your thoughts.
So this is highly speculative, obviously, because the short answer is that I don't know. It is the honest answer too. We know that there appears to be a strengthening of the connection, and in general, there appears to be a strengthening of integration among key cortical and, particularly our target, our limbic target. The durability and I would say the order in which it happens in terms of which processes are more preeminent at the beginning and then become secondary at the end, we don't know. So it could be that it starts, in clear occipital lobe, just visual processing, and then slowly moves up to cuneus and precuneus and becomes more of a cognitively mediated task. But we don't know. I mean, that is a fascinating question, right? What are the processes that are underpinning the potential success of this treatment, especially given the fact that it's so expensive? And if it was up to me, I would try to find a way to do it outside of the scanner, right? So we know this works. How can we replicate this just in a regular psychologist office? We have some hints with regards to the amygdala specifically. I don't know about visual cortex. We would have to look at it. But what we're noticing is that if you train the right amygdala, so I have some preliminary data for the child data, but the good news about that is that the sample is bigger, is about 100 kids. So what happens is the right amygdala tends to be hypoconnected before neurofeedback. Then it becomes highly connected during neurofeedback, and then afterwards it switches to the left. So we wonder if what is happening is that automatic processes that were somewhat defective at the beginning are brought under control, and then they're using it correctly afterwards. Because in our results, there's this tendency of individuals that are primarily depressed to have high right amygdala drive and individuals that are healthy have high left amygdala drive. So it gives you an idea of where the processes might be going. But that is just specifically to amygdala connectivity. And I can actually show you the data to how they look before and after they essentially switch. Unfortunately, we don't have a control group here. They're all, they're the more difficult and risk population that you can probably select. Although there are more risk people than these. So that was somewhat of a, circumlocuitious answer, but it's the best that I can do for now. I can give you my
Great.
data. You can analyze it.
Yeah, thanks. I recognize that we're over
Yeah.
time. So I want to thank all of our speakers again.
Sure.
And thank you all for your attendance. If you have any other questions, please feel free to stick around and chat.